All right, once you've allowed your inking to dry, and it may take a little while to do that, then you will want to go ahead and begin prosecting your specimen. So the first step in doing that is, of course, making sure that you're maintaining your orientation. You want to make sure you have your epiglottis on the superior aspect of the specimen, and the pig version of the hyoid bone is also on the superior and then anterior aspect. Your thyroid cartilage is anterior, and then looking at the bottom you have your tracheal rings. So the way to open the specimen is go ahead and insert your scissors on the inferior aspect of the specimen through the tracheal rings and begin cutting. One of the first things that you will notice is that the cartilage is pretty firm. So you'll want to be very careful in cutting, and so you'll need to use a little bit of force while doing that. After you've cut through, and make sure you cut through the middle of your two cartilages, then one easy trick that you can use is a wooden stick to help prop open the specimen. So go ahead and take your fingers and open your thyroid cartilage. And then the way to take the stick is just place it right in front of that cricoid cartilage, and then kind of spread out the cartilage to about the size you want it, and then break the stick and place it in there. This is a specimen where you'll probably want to change your gloves a decent amount if you notice that you're getting ink on your gloves or on the specimen itself. So I'm going to go ahead and change my gloves. And then you may also notice some of the ink that got on the mucosa. So at this point, what you want to do is take either a Q-tip or a sponge or any other dry, like a paper towel, something like that, and then just go ahead and start dabbing that inside of the specimen. And you may notice I'm using a sponge. You can use the sponges to actually help apply that black ink on the outside of the specimen. It helps it go much faster. Okay, so at this point, for this lab, right, we are going to be prosecting this larynx as though it had a subglottic lesion. So I'll review the anatomy here in a second, but I'm going to go ahead and place some red ink to simulate a lesion in the subglottic region of the specimen. And we will allow it to dry. Okay, so while we do that, I'm going to go ahead and just review some basics that I want you to be aware of. So let's start on the most superior aspect of the specimen. You have your epiglottis, and then anterior to that, what is the important space that we need to be thinking of? It's the pre-epiglottic space. So that's all the soft tissue anterior to the epiglottis is part of the pre-epiglottic space. Lateral to that, we have our piriform sinus on either side. We have our aryepiglottic fold. It's this nice little soft fold of mucosa here. We have what would be our cuneiform and corniculate cartilage. Moving down, we want to identify our false cord, which is up here. Underneath that is our ventricle. So everything from the false cord superior is our supraglottic space. Supra. It's above the glottis. Next, we want to identify our true cord. So we have our ventricle, then we have our true cord here. Now, in the ventricle, the most anterior aspect of that, we would have our anterior commissure. What is our anterior commissure? Our anterior commissure is the dense ligamentous attachment of the vocal cords to the thyroid cartilage. Again, the anterior commissure is the dense ligamentous attachment of the vocal cords to the thyroid cartilage, because remember, the thyroid cartilage is anterior to the specimen here, right? So the most anterior cartilaginous portion of the specimen is the thyroid cartilage. This is our cricoid cartilage here. Okay, so again, this is our true cord. So 1 centimeter beneath the ventricle, I don't know if you guys can see that or not, is the glottic region. So there's another important space that you need to be aware of, and that's the paraglottic space. So the paraglottic space is anterior to the true cord, to the glottic region, and posterior to the thyroid cartilage. Okay, it's not any specific structure or anything that you're going to see. It's literally just the space between the space anterior to the true cord and posterior to the thyroid cartilage. The preepiglottic space, the piriform sinus, and your paraglottic space are very important for staging. If there's tumor extension there, it could be indicative of a poorer prognosis, because again, there's more advanced local disease. Okay, so I'm gonna go ahead and just apply a little bit of vinegar to my red lesion. I'm actually gonna put it on the paper towel first and then place it on here. Okay, so what are important things we need to think about when we're measuring a lesion? Well, we have our lesion here. We can measure it in 2 dimensions at this point. We would measure our 3rd dimension after we are done cutting through it. So we have a 1.6 by 1.1 centimeter lesion, which is located. Well, this is an area I often notice students make a mistake, is when they're measuring the distance of a tumor to something, they measure from the center of the lesion or an area that's not truly the closest. So if you look at this here, what you could see is that this area right here is where the lesion is closest. So that's where I'm going to measure. I'm not going to measure from over here or my perceived idea of where the center is. It's always the closest distance. So right here, we're at 0.9 centimeters from that inferior tracheal margin. All right, the next important structure you'd want to give a relationship to would be the glottis or the ventricle. So it's located .7 centimeters from the ventricle. It does not cross the midline. And then if we wanted to give our distance to the superior mucosal margin, I would look for my green ink. I see it here. And so here we go. It's about 6.5 centimeters from the superior mucosal margin. So we know we're a good distance away from that superior mucosal margin, so I'm going to go ahead and shave that margin before I proceed with prosecting my lesion. So there's a couple ways to approach this. The first way I'll show you is with the blade. So you'd want to kind of cut. And then start to kind of shave. Okay, so there's an example of shaving that margin. Okay, you can be specific about what areas you have in your superior mucosal margin. So what areas do you need to include? Well, you need to have your mucosal margin in your preepiglottic space, in your piriform sinus, and then in your cricoid mucosa. Another way to approach taking this margin, because again, the lesion is more than 1.5 centimeters away. So how am I going to submit this margin? I'm going to shave it and I'm going to submit it on FOSS. Okay. All right, so those are the two ways I used scissors and I used the blade. So in my cassette summary, I would be very organized. I would have my left cricoid mucosa, my piriform sinus, superior mucosal margin, my pre-epiglottic space, superior mucosal margin, and I would designate left versus right. So you'll want to go ahead and do that, go all the way around and sample each of those sections. So the other thing would be now taking my other sections. And so I want to take a section of my epiglottis. So you can go ahead and take your blade or your scissors and cut down. And then all right. So what you'll notice that I have taken is not only the epiglottis, but also the pre-epiglottic space. So at this point, you have kind of a nice section that you can then bisect to submit in two different cassettes. So you have your epiglottis section and your pre-epiglottic space. Okay. Now some of these might be a little thick, so you want to trim. Remember, we want to keep our sections between 0.3 and 0.5. One thing I want you to keep in mind with the larynx is that due to the nature of having cartilage, soft tissue, muscle, fat, and then the mucosa, you have very different textures. So that's one area where students tend to get frustrated, is as they're cutting, things tend to move around on them. So for example, here we have maybe a little bit thicker portion of cartilage with our epiglottis here. So, and then you notice like the thin, nice soft tissue here. So what can you do in this situation? Well, you're going to want to trim it up a little bit when it gets to be too thick. And so one way to do that is to kind of take the cartilage and place it on its side and then trim off a little bit. And I will show you that when we get to the cords. So you can kind of trim a little bit, because this is the section I'm putting down. So something along that would be one way to trim. All right, so continuing on with our important sections that we need our area epiglottic fold and our piriform sinus. So let's see, here's a good spot. So again, you'd want to do representative on each side. Go ahead and cut down, have our area epiglottic fold. And there we go. Okay. Now as far as our cartilage is here, you can actually use your scissors. Remember, we can turn things around. They don't always have to be all in the same plane. So we want our cartilage and our mucosa here. Okay, so now I have my cartilage and I have my mucosa, area epiglottic fold. Okay, so then that can go in a cassette. And you would do the same on the other side. So now let's draw our attention to our lesion. So we measured our lesion, we measured the distance to the margin, but we're missing one other margin. And what other margin is that? It's our deep margin, or our radial margin. So one, we need to cut through the specimen to be able to measure those distances. Now when you guys are prosecting tumors, you may notice I took some other sections before I started cutting through my tumor. Why did I do that? Well, when you have a friable tumor, which sometimes squamous cell carcinomas can be, they may be friable. So it's something to be mindful of when you are cutting tumors, that you don't necessarily want to cut through a tumor and then take a bunch of other sections like your margin. You may want to kind of save your margin and then always change your blade after cutting a tumor, just to make sure you're not contaminating or at least cleaning your blade with the same case. So now I've sectioned through the rest of my lesion. So I'm going to examine. So it looks like my lesion does not extend beyond 0.1 centimeters. So then I would, state the third dimension of my lesion. But what else do I need to measure? Again, I need to measure the distance of my lesion to that deep margin. And so I look on both sides, okay, throughout my specimen. All right, so it's pretty consistently about the same. Looks like no greater than, I would say, about 0.3 centimeters to that deep margin. So this section is gonna go in the cassette. Due to the fact that the cartilage is a little thick, I am going to trim a little bit here. Okay. So now we have a nice thin section, and we're going to place that in the cassette. We could also place this other section in there. Okay. Since this lesion is pretty small, I would probably put through the rest of it just because it's not very big, and then trim accordingly. Okay, now that we've done that, we need to take our other sections that are important, right? So I talked about the paraglottic space being important. We also need our transglottic sections. So our two transglottic sections need to include false chord, ventricle, true chord. And the other transglottic section should be your anterior commissure, which should be taken about right down the middle here to include the true chord, false chord, and ventricle. So I'm just going to continue my cut. And again, now you can start to see where things get frustrating, because as I'm cutting, the mucosa draws away from the underlying tissue. This is a good example of something where we call something almost like a bulging. So cut surface, this would be almost like where the tissue underneath is kind of coming out. It's relieved to now have been cut. It's no longer under such tight tension. So again, now I'm going to take my representative section here. Okay, so I can see that I have true chord, false chord, and my ventricle. So just try to keep your orientation as best as you can here. Okay, so now I have my transglottic section. All right, so for pieces like this, where the cartilage ended up being a little thick, I can see that that side looks nice and smooth too, so I'm gonna go ahead and just trim from this side. So I'm just trimming my cartilage. Okay, so that part can get a little frustrating when things start to move, so just be patient with yourself. And there we go. So that would be our transglottic section, and I would place that in a cassette. And as far as size of tissue, that's about the max that you would want. I could actually probably trim a little bit of that cartilage from each side to just tighten it up a little bit. Okay, then the next section would be our anterior commissure. So then you want to cut just to the side of that anterior commissure so that you can actually get it on edge in the cassette. And all right. Alrighty. So I'm going to use my scissors to make that last cut there. Perfect. Awesome. Okay. Here we go. All right, so there's my anterior commissure. So I'm gonna go ahead and trim. This is also an opportunity, if you guys would like to try it, to use your paddle forceps. Those are also an option. Now I'm noticing I'm coming into some really firm areas of the cartilage. If that's the case, I don't want you guys to force cutting anything. That's a great way to cut yourself, is to try to force a blade into a specimen. So if this was a human specimen, we would want to place it in a little bit of decal if we were having issues cutting through some cartilage. All right, so now I'm gonna just go ahead and trim this bottom part here, some of our tracheal rings. Okay, and then let's see. I definitely don't need this whole long piece of tissue. I can see that the commissure is right in here. I can actually probably just cut there. I'll give this one more go. That's not going. Okay. So at that point, don't worry about it. I just want you guys to have at least a representative section. If you can't cut through it, again, do not force it. We can try playing around with some decal in lab. So that would be your other section that you need to take. Some of the larynges are very easy to cut through. Others, again, are a little bit more calcified and difficult to cut. So just keep that in mind. Let's see. Now, as far as the rest of our sections here, again, make sure you get your entire superior mucosal margin. You have a tumor to deep section and then tumor to the inferior margin. Now the rest of this margin you can go ahead and shave and submit on FOSS. You also want to make sure you have representative sections of your transglottic section from either side. One other note is that you are prosecting the specimen. It will get cut apart. So if once you're done with it, it looks pretty chopped up, that as long as you know your orientation when you were creating your cassettes, you should be in a good place. Now, before I close this video, just one other thing to think about. What would you do if your lesion was in, say, your supraglottic region? If it was somewhere around here, would you shave your mucosal margin? Would you take a perpendicular section? What if it was in your glottic region? So always be aware of how your prosection could change potentially as far as your margin submission in those situations. For example, if it was in your glottis and it was a good distance away from your inferior tracheal margin, maybe you would just shave that margin. And if it was also a good distance from your superior mucosal, there could be a chance you would also just shave that. However, if your lesion was in your epiglottis or in your supraglottic area, then of course you might have to take a perpendicular. You might have to then cut through the lesion, of course you would, and then change where you take your sections and how you submit them. So I hope that this video was helpful, and please let me know if you have any questions and we can go over it again in lab. Thanks.